Good morning everyone. So we are beginning with the neurosurgery series. So we are going Star Wars for this one. Beginning with Chapter 7, CNS Tumors. Part A, General Aspects of your CNS Tumors. So the CNS tumors we are going to see under two headings, that is your intracranial tumors and intraspinal tumors, which are classified on the basis of their location in the nervous system. So for this session and for the part B, we are going to focus on the intracranial tumors. So the intracranial tumors, they can be classified as primary versus secondary, pediatric versus adult. They can be classified by the cell of their origin and by their location in the nervous system. Location in the nervous system, in case they can be cerebellar, they can be in the cerebral cortex, they can be the brainstem, they can be originating from the ependyma and going into the ventricles. So what is primary versus secondary intracranial tumors? So primary tumors are tumors which arise from your tissues in the nervous system. Okay, so they're basically going to arise from your neurons or from your neuroglia, mainly from your neuroglial tissue. While your secondary brain tumors, they do not have origin in the nervous system. They're going to originate from tissues outside the nervous system and they're going to metastasize secondarily to the brain. Now this metastasis is usually through the hematogenous route, or they can come from local extension of regional tumors such as your chordoma, scalp cancer, etc., and then they're going to reach your nervous system. Okay, now continuing as to how the brain tumors produce the signs and symptoms, we are going to study its pathophysiology. So the parenchymal brain tumors, they're going to produce symptoms by three mechanisms. They can either cause tumor cells can infiltrate the normal brain parenchyma. The tumor cells can cause mass effect, or they can cause both, tumor cell infiltration plus mass effect. Now tumor cell infiltration, I want you to imagine that the tumor cells, they're actually infiltrating the normal axons, the normal neurons. Okay, so the tumor cell infiltration occurs along nerve fiber tracts in both the white matter as well as the cortex. So it is both in the white matter as well as in the gray matter. The tumor cells are infiltrating the normal nerve fibers. It is usually seen with low-grade tumors like low-grade astrocytomas and oligodendrogliomas. They usually behave in this fashion, and the symptoms that they are going to produce is they are going to produce seizures. Now tumor cells can also grow into a mass. They are going to displace but not destroy the surrounding brain tissue. So you can imagine a tumor, it is causing mass effect, that is, it is displacing the normal tissue. Because skull is a closed cavity, in the same space, both the tumor as well as a growing tumor as well as the normal brain parenchyma is residing. So they are competing for the space. So what the tumor is doing, it is pushing away the normal brain parenchyma, but it is not destroying the surrounding brain tissue. It is usually seen with your METs, that is your metastatic brain tumors. They typically grow in this way. The patient presents with symptoms and signs of an intracranial mass, which often resolves after treatment. So you remove the tumor, the competition for the space is gone, even the symptoms, they reside. Now your malignant gliomas, okay, they are malignant. They are going to behave in a combination of tumor cell infiltration and growth as a mass destroys the surrounding neutrophil. Neutrophil is your normal brain parenchyma. Now malignant gliomas, they are going to behave in this fashion and they are going to produce symptoms and signs that may not improve even after treatment. You're not going to have a good prognosis. One more thing about these mechanisms, although each mechanism takes place independently, there is considerable overlap occurring between the three mechanisms, and as the tumor is going to evolve, all the three mechanisms are going to come into play. Continuing on to the pathophysiology of signs and symptoms of intracranial tumors. So the tumors that arise outside the brain parenchyma, they rarely infiltrate into the neutrophil, and instead they are going to produce their symptoms by compressing on the adjacent brain directly and by the production of cerebral edema. So this is going to like compress the brain parenchyma, and it can also produce edema because it's kind of a foreign body, so edema can be produced. These tumors, they present only as a mass. They can have focal symptoms, like if this is going to compress on the premotor or the primary motor cortex, so it is going to produce weakness. If it is compressing on the sensory cortex, so it is going to produce sensory symptoms. Present only as a mass, they can and they cannot produce. So they cannot produce focal symptoms, they can produce focal seizures in the underlying brain. Now the intracranial lesions, they characteristically produce progressive symptoms, and the progression of the symptoms is going to vary a lot. Now the rate of the progression, it can vary from an acute apoplectic onset, like for example inside the intracranial neoplasm there is just a hemorrhage or bleeding, so it may cause a seizure because of cortical stimulation, so it's going to be very acute because of the bleeding. And it can also vary to progressive mental deterioration, so it can be very like slow, taking over years, or it can be very quick. Like for example, a patient of a low-grade glioma may have seizures for months to years, and then he's going to have progressive neurological signs only in the late course of the disease. By contrast, a malignant glioma, it may produce headaches and focal neurological signs only over a few weeks, because the malignancy will have a very quick progression. Now the brain tumor symptoms, they can be generalized symptoms involving the entire cortex, or they can be focal symptoms. So the generalized symptoms, they are primarily because of the mass effect. Mass effect is primarily your tumor is creating raised intracranial pressure in your brain, or they can be focal symptoms because of direct compression. Like I told you, motor cortex and sensory cortex, that is going to be direct compression, or it can be infiltration into the surrounding neutrophil. Okay, now let us discuss the phenomena of plateau waves that are seen in brain tumors. So sometimes in the cases of brain tumors, there would be sudden increase in the intracranial tension for only 5 to 20 minutes. That is going to result in an abrupt headache or worsening of neurological signs. So these episodes on intracranial pressure recording is going to produce a wave or an increased wave for that 15 to 20 minutes duration, and that is known as the plateau waves. So plateau waves phenomena is seen on intracranial pressure recording in a case of brain tumors. Okay everyone, so now let us discuss a life-threatening complication of brain tumors, that is herniation syndromes. Now we know that the skull is divided into different compartments by the dura mater. The dura mater is comparatively very inelastic, so an expanding mass in one compartment will force the brain tissues through the openings between the dura mater. And when the brain parenchyma is going to be pushing through this foramen, it is going to tear the blood vessels and it will compress the neuropil of the opposite side. So your herniation syndromes can be of two types. They can be either unilateral or they can be central. So unilateral herniation syndromes are subfalcine or cingulate herniation. It is uncal herniation or central or lateral transtentorial herniation, and your tonsillar herniation or the cerebellar herniation. Now your central herniation is central transtentorial herniation. Now we are going to study each herniation in depth. So a unilateral cerebral mass which may force the medial surface of the brain beneath the falx cerebri. Okay. So this is your falx cerebri, which is going to divide the two cerebral hemispheres. If a tumor is over here, it is going to create pressure, and the parenchyma of the ipsilateral side is going to move through the subfalcine area and compress the brain parenchyma on the opposite side. So this is known as subfalcine herniation. It is also known as the cingulate herniation because the cingulate gyrus usually herniates. Subfalcine or cingulate. You need to remember these two terms. Subfalcine, cingulate are the same thing. Next comes your uncal herniation, which is also known as your lateral transtentorial herniation. Now it occurs when the mass is unilateral, especially if it is in the temporal lobe or the medial temporal lobe, and it is displaced inferiorly and medially through the tentorial notch. So the your hippocampal gyrus, it is primarily going to move inferiorly and medially, causing your uncal herniation or your lateral transtentorial herniation. Now let us talk about the tonsillar herniation. So what happens in the tonsillar herniation? It occurs because of the displacement of the brain tissue through the foramen magnum. Okay, so this is your foramen magnum from where your brainstem is arising. Is leaving your cranial cavity. Also, your uncal herniation, it actually moves through the tentorial notch. So what is a tentorial notch? There is your tentorium cerebelli, a fold of the dura mater which separates your cerebrum from the cerebellum, and there is a gap in it through which the brainstem passes. That is called your tentorial notch. So from the tentorial notch, if the cerebrum ka part, that is your usually your temporal gyrus, if it goes down, that is known as your uncal herniation or lateral transtentorial herniation. Now coming to your central herniation. How will the central herniation occur? It occurs when the mass effect is produced from bilateral sides. So it is going to be from both the sides. And it is symmetrical, and it will cause a downward shift of your diencephalon, which will be here, and your upper brainstem, it will move down through the transtentorial notch. So that is your central herniation. So let us see how overall it will cause the compression, what will be the effects. So the tumor and its edema will produce herniation. So the cingulate gyrus herniation will be under the falx cerebri, and diencephalic herniation across the midline will compress the ipsilateral ventricle, and it will produce hydrocephalus in the contralateral ventricle. So this will compress here will be your ventricles, so it will cause compression of that ventricle. Moving on to your hippocampal gyrus herniation through the transtentorial notch, it will compress your PCA because the posterior cerebral artery would be lying over here. So your transtentorial lateral transtentorial or your uncal herniation, the hippocampus usually moves down, and hippocampal gyrus moves down, and it will compress your PCA, that is your posterior cerebral artery, and also you can see it is compressing your brainstem. This part is your brainstem. It will be going till here. Your brainstem has taken origin. Diencephalon and brainstem will be compressed. This is your cerebellum. And the herniation of the cerebellar tonsils will occur through the foramen magnum. So all these herniation syndromes are quite an emergency condition, and they require quick pressure control. So now we are going to discuss the clinical manifestations of various herniation syndromes and the pathogenesis underlying it. So we are going to begin with central herniation, in which the diencephalon and the brainstem are going to herniate, causing various symptoms. So the diencephalic compression is going to cause decreased consciousness, small pupils, and Kienstrok's respiration. The compression of the midbrain and the upper pons is going to cause mid-position fixed pupils and absence of the oculocephalic reflex. So what is the oculocephalic reflex? That if in a normal patient, you passively turn his head to one side, the eyes do not move, they remain fixed to one point. While in a patient who has an upper brain lesion, that is supranuclear palsy, in that patient, if you passively move his head to one side, the eyes will move with the head. So that is your oculocephalic reflex is absent. I'm going to share a link of a video which you must watch. It is not by me. It is done by some doctor probably. So do watch it. It has explained oculocephalic reflex, and that is your vestibulo-ocular reflex, in a very good way. Next, in the midbrain pons compression, you will see abnormal motor signs and hyperventilation, because you know that the pons has, in the upper pons there is a pneumotaxic center, lower pons has the apneustic center, and the medulla has your DRG VRG group of neurons, which are your respiratory centers. So since the pneumotaxic center will be gone here, apneustic center will take over, so there will be hyperventilation. Coming on to lower pons medullary compression, it will cause decerebrate posturing due to cutting off fibers coming from the pons as well as the medulla, and it can cause apnea, as I told you, because it houses the DRG and VRG group of neurons. Apnea can cause death. Also in this patient you will see that the pulse has gone down and the blood pressure has increased. Moving on to tonsillar herniation manifestations. So what happens in the tonsillar herniation is basically your posterior fossa mass will push your cerebellar tonsils through the foramen magnum, and that will go and compress your medulla. So here the symptoms are going to be because of your compression of medulla. So there is going to be rapid loss of consciousness, there is going to be stiff neck and vomiting, and skewed deviation of eyes, irregular respiration, and death. As you know, medulla has your respiratory center, the pre-Botzinger complex. So what is meant by the skewed deviation of eyes? Skewed deviation of eyes means your eyes are aligned in different vertical planes. So like here, like if the person is asked कि gaze सामने देखो बोला उसको, so what happens is one eye will be here but the other eye will be in different vertical plane. Similarly, if one eye is pointing this way, other eyes will look in some other vertical plane. It is not going to be in the same vertical plane, it is going to be in a different vertical plane. Okay, coming on to uncal herniation. The manifestations are basically because of the temporal lobe herniation through the tentorial notch, and it is going to compress various structures. If it compresses the ipsilateral third nerve palsy, there is going to be the same side, ipsilateral third nerve palsy will be there. If it compresses the posterior cerebral artery, it will give rise to homonymous hemianopia. Why homonymous hemianopia? Because it is going to supply your occipital cortex, which is going to get one nasal fiber of the optic nerve and optic tract and one temporal fiber, giving rise to homonymous hemianopia. If it compresses the midbrain, then there will be obtundation leading to coma. Even coma can occur. Whenever brainstem is involved, it's going to be very severe things. Hence, all these herniations are very are emergencies. These are surgical emergencies. Contralateral hemiparesis can occur in midbrain compression because, as you would be knowing, your pyramidal tracts and your tracts are passing through your brainstem. So they can be decorticate or decerebrate rigidity depending on which lesion, where the lesion has affected. They can also be kind strokes respiration. There can be opposite side cerebral peduncle involvement because the herniation is going to, like, herniation is coming from here, so it will compress, it will cause compression against the bone of the cerebral peduncle. So there will be ipsilateral hemiparesis because what happens is tracts have crossed, okay, and the herniation will compress your opposite cerebral peduncle against your dura, and it will cause towards the side of the tumor there will be ipsilateral hemiparesis because of the crossing. I hope you understood. Okay, so now let us talk about seizures in brain tumor. So intracranial tumors, they can produce both generalized major motor conversions as well as various forms of focal seizures. But you've got to remember that in a neoplasm, you will never ever see petit mal epilepsy. Petit mal epilepsy is nothing but your absence seizures. So petit mal epilepsy is never due to a neoplasm. But your minor temporal lobe tumors, they can present with seizures that can be partial, simple or complex seizures that may resemble petit mal attacks, but they are not petit mal epilepsy. They are going to just resemble it. So along with that, your temporal lobe tumors, they characteristically, because you remember temporal lobe is primarily associated to your radiations are going through it, your optic radiations pass through the temporal lobe, and it is kind of linked to your emotional center, it's linked to your limbic system and all, so it is going to produce your psychomotor seizures, also known as partial complex seizures. Now the term partial complex is the old term. Partial seizure is when only a part of the brain is stimulated, and complex seizures are associated with loss of consciousness. So it was an old term, not used now. So psychomotor seizures are produced by temporal lobe lesions. So what all are you going to see in this? You can see olfactory hallucinations. Okay, so your psychomotor seizures, they may be associated with olfactory hallucinations. If they have olfactory hallucinations, it is known as uncinate fits. It can also be associated with disorders of visual or auditory perception, because auditory, temporal lobe, visual because your optic radiation is going to pass through the temporal lobe. They are associated with episodes of deja vu. Deja vu is a sense of being, it is actually an unknown situation for you, but you feel that you have been in that situation. So it is associated with deja vu and automatic behavior. Automatic behavior is like lip smacking and all would be there. He would be doing something like that. Now seizures, both general as well as focal, they occur in almost 25 to 50% of the patients with cerebral tumors. Now you need to remember that these seizures, they are more associated with slowly growing tumors than the rapidly growing malignant neoplasms. And they are most commonly associated with low-grade astrocytomas and oligodendrogliomas. They are more likely to present as seizures than other tumors. In fact, you can remember that low-grade tumors and seizures have such a common linkage that a single episode of seizure has now become the most common presentation of a patient with a low-grade glioma diagnosed by MRI. And in fact, now a syndrome of low-grade gliomas has been identified as a cause of chronic epilepsy. So if you're going to come across a table with causes of chronic epilepsy, you're going to see a subheading, or you're going to see a cause as low-grade gliomas. This much is the relationship of low-grade gliomas with seizures. Okay guys, now let us discuss a very important scoring system related to CNS tumors known as the Karnofsky Performance Score. Now in the KPS, what we do is the physician, he assesses the patient's clinical symptoms and signs, and these clinical symptoms and signs that are reviewed alert the physician to the possibility of the occurrence of a brain tumor in the patient. Not only that, it also helps us to look, it gives us an idea, a clue to the localization of the brain tumor, and the same clinical features may be used to follow the patient during treatment, and they may also be used to combine and to semi-quantify their quality of life post-treatment. In fact, it is such an important score that in the early days of cancer chemotherapy, Karnofsky and Burchenel established criteria for patients' performance status as one measure of the outcome of the treatment of the brain tumor. So the KPS, Karnofsky Performance Score, quickly became a standardized tool for expressing such outcome and was adopted for brain tumor treatment studies. So the KPS has become a very important and mainstay of brain tumor studies. Now KPS, it is a 10-grade scale and it describes the patient's capabilities of performing tasks. So now let us see the result. In the next slide, I'm going to show you the KPS scoring, the entire 10 grades. Here let us look into the result of the KPS scoring. So if a patient has a KPS score of 80 to 100, it means that the patient can work or maintain a home. If his score comes In the range of 50 to 70, it applies to patients whose clinical status prevents them from working. And KPS scores below 40 apply to patients who are disabled. Okay, now let us study what are the parameters covered in the Karnofsky performance score for brain tumor patients. Okay, so as I said, it is a 10 grade scoring system. So it is 10, 20, 30, 40, so on till 100. So a score of 100 is for an absolutely normal patient. He has no complaints and there is no evidence of disease in this patient found. A score of 90, so as you go down, the condition of the patient worsens. A score of 90 means that he is able to carry on normal activity, but he has got minor symptoms, very minor. A score of 80 means he is able to carry out normal activity with effort and he has got some symptoms. A score of 70, that he can care for himself but he is unable to carry on normal activity. 60 means he requires occasional assistance and he can care for most of his needs, but in between he'll require some assistance. A score of 50 means he requires considerable assistance and he requires frequent care. Okay, so he can take care of very little things. Frequent care is required and he's going to require a lot of assistance. A score of 40 in a brain tumor patient means comes when the patient is disabled and he requires special care and assistance. A score of 30 is for severely disabled patients who are hospitalized, but their death is not imminent. Death is not waiting for them, but they are very severely disabled. A score of 20 means they are very sick patients. They are going to require active supportive treatment. And 10 is for moribund patient and the fatal processes are rapidly progressing. You cannot save them from dying, even like whatever you do, chemotherapy, radio, surgery, they're going to die of the brain tumor. Okay, so now we're going to play a very little game. The heading is localization of the lesion. So you're going to have signs and symptoms given and you have to localize as to which part of the cerebral cortex or your diencephalon, which part of the brain has got involved. Okay, so let us start. So if there is Jacksonian march taking place, the patient is having focal seizures. It started from the tip of your finger and it is going from your hand, forearm, arm, and it is proceeding. So which part of your brain is involved? Okay, the answer is it is centroparietal cortex. So I already have told about that, that in your brain you have got your primary motor, premotor and your sensory cortex. So over here you have your homunculus representation, and if the lesion has started, if the lesion is over here, that is in the centroparietal cortex, so what will happen is it will just stimulate a part and then the seizure will go on progressing. That will give you Jacksonian march. Okay, next point is your partial or psychomotor seizure, already taught. Yes, it is temporal lobe cortex. So it is your temporal lobe affection. Now coming to visual disturbances. If a person is having altered visual acuity, so where in your optic nerve pathway will there be the lesion? So it can be either in the eye or it can be in your optic nerve. Coming next, hemianopia or quadrantanopia. So since a big heading has been involved, the answer is moving from the cortex towards the eye. Let us come. It has to be your opposite lateral geniculate body. There can be involvement of your optic tract, optic radiation and optic tract. Okay, now and they can also be involvement of your occipital cortex or your occipital lobe. Now you need to know that your optic radiations, they actually pass through your two lobes, that is your temporal and parietal lobe. Since there will be affection of only one lobe, temporal or parietal, they give rise to quadrantenopia. Now coming to bitemporal field cut. Bitemporal, the temporal field is lost. It means both your nasal fibers are gone. Where are the nasal fibers so close by? Answer is chiasma. So which tumors will mostly be causing your bitemporal field cuts? What is sitting just above the optic chiasma? Pituitary. So your pituitary tumors will be causing bitemporal field cuts. Now coming to diplopia and nystagmus. So it's primarily nothing to do with vision now. It is diplopia, nystagmus. It is something with the extraocular muscles. What is mostly supplying it? The third cranial nerve. So it is something related to your oculomotor nerve or its connections. Okay, now moving on to the language and speech disturbances. If your patient is having dysphasia or aphasia, can be taken together, expressive as well as receptive, in which area would you suspect the tumor is lying? So it would be in the speech centers. Speech centers, but in which hemispheres? Which hemisphere? So it has to be the dominant hemisphere. In case it is an expressive problem, so it is usually the Broca's area is involved. So it would be a problem in your dominant frontal cortex. And if it is an receptive problem, that is your Wernicke's aphasia, it would be in the temporoparietal lobe. Temporoparietal lobe. Now if your patient is having dysarthria and not dysphasia, so where would you suspect? So it is a kind of a movement problem. So movement problem, whenever we think, what comes to our mind? We think of cerebellum or the brainstem ganglion. So usually of the dominant cerebrum, we are going to have involvement of the posterior fossa. So the tumor will be lying usually in the posterior fossa. Now if your patient has got hearing disturbances like deafness, vertigo, yes, you're right, the first thing that comes to your mind, vestibular schwannoma. So it can be the tumor is lying in the 8th cranial nerve or in the CP angle, that is your cerebellopontine angle. Okay, coming on to motor disturbances. If the patient is complaining of weakness, example in his right half of the body, so what would you expect? In the left-sided, it is a left-sided corticospinal tract involvement. Now we know that the corticospinal tract, it moves from your cerebral hemisphere through the cerebral peduncle to the brainstem and then to the spinal cord. So the involvement can be either in your cerebral hemisphere. I'm sorry for the handwriting, to write by tilting a little actually. It can be in the cerebral peduncle or it can be in the brain stem. So the tumor can lie in either of these. If he's complaining of incoordination like clumsiness, dysmetria, so the problem would be in the tumor would be lying in your posterior fossa. Which structure is involved? Your cerebellum. Now coming on to sensory disturbances. If the patient is complaining of dysesthesia, so what is the meaning of, first of all, dysesthesia? Anesthesia. What is anesthesia? Not feeling anything. Dysesthesia is you're getting a very abnormal sensation, like something badly different. So dysesthesia, it occurs because of involvement of your spinothalamic tract. If there's a proprioception problem, it would be involving your posterior column. Your posterior spinal tracts, it can either be there, it can, then you know that the dorsal column goes to the thalamus and then to the thalamoparietal connections. If the patient is having numbness, so he's not feeling any sense at all, the problem is in your thalamus. Why thalamus? Because all your it is the relay center. So all your ascending tracts are going to first come to the thalamus, and then the thalamus will let it go to the cerebral cortex. So the patient is not feeling anything at all. See, it cannot be complete section of the spinal cord or brainstem. So it has to be a thalamus involvement because he's just having numbness. Then if he's having problem in cortical discrimination, so it will be involvement of your parietal cortex. Now, if you're talking about gait disturbances in the patient, if your patient is complaining of weakness or sensory problem, so the lesion can be in your corticospinal tract or your spinal pathway. Sorry, or your sensory pathway. I'm sorry. If the patient you're noticing is having ataxia, what would be involved? Yes, cerebellum. So where would you find your tumor in? Your tumor would be found in the posterior fossa. Now if the patient has apraxia of gait, now apraxia, whenever it comes, it's usually related to your frontal cortex. So this patient is having your bifrontal lobe affection. Okay, now coming to urinary disturbances. If the patient is having incontinence, you are suspecting brain tumor, what area of the brain would you localize it to? It is the medial frontal lobe. Why? Because you know that if this is your cerebral cortex, on the central area, this much part is known as your paracentral lobule. And your paracentral lobule is responsible for your urine control through the cortex. So your urinary center is actually in the paracentral lobule, which is on the medial frontal lobe. So if your patient is having incontinence or any urinary disturbances, you are suspecting a tumor, it will be usually in the medial frontal lobe. Okay, now finally coming to the clinical presentation in general. The clinical manifestations of various brain tumors, they can be divided into those caused by focal compression and irritation by the tumor itself, and those which are attributed to secondary consequences, namely increased intracranial pressure, peritumoral edema, and hydrocephalus. The clinical presentation does not differ much by the tumor histology, but rather by the rate of growth and the location of the tumor. For example, a meningioma which is peripherally located and is relatively small in size and is in the silent area of the brain, and it is growing at a very slow rate, may enlarge to a significant size in a neurologically intact patient because the brain can accommodate to a slowly growing lesion. On the other hand, a small metastatic lesion at the foramen of Monro or in the sensory motor strip can cause acute hydrocephalus or seizures respectively. So if it is, so the location, it depends on the location and the rate of growth. If it is a slow growing tumor, your brain can adapt to it and there will be not much features, and also on the location, if it is peripherally located, not much of symptoms, but if it will be located at the foramen of Monro or from where the CSF is draining, it can cause acute hydrocephalus and hence present. Or if it is located on the sensory motor strip, it can result in seizures, as we saw in the Jacksonian march. Another, now come to the important presentations as to how your CNS tumors can present. This was the reason why they present, and here is how the presentation starts. So the first presentation, it is headache. So how headache is it is associated with 50 to 60% of the cases of primary brain tumors. They present with headache, and 35 to 50% of the metastatic tumors, they present with headache. Now these headache, the characteristics of this headache is, it is classically described as being worse in the morning Now, for it being worse in the morning, there's a reason. Because of hypoventilation during sleep, there is going to be elevation of PCO2. Your hypoventilating parasympathetic system is stimulated when you're sleeping. There will be hypoventilation, PCO2 increases, and this will cause your cerebral vasodilation, which will cause headache. Now, most of these headaches, they are associated with nausea and vomiting in 40% of the patients, and they can be temporarily relieved by the vomiting. Now, how are they relieved by vomiting? Because the patient during vomiting is going to hyperventilate. This will decrease your CO2 and the vasodilation will be relieved, so your headache will improve. Now, another common symptom of CNS tumors is seizures. In fact, seizures may be the first symptom of a brain tumor, and in patients more than 20 years who present with new onset seizures, they are in fact investigated for the presence of a brain tumor. It is a kind of protocol. Infratentorial lesions, now we're going to see the presentation of infratentorial lesions and supratentorial lesions. So what is tentorium? We're talking about tentorium cerebelli. So imagine the anatomical structures. According to that, you will have the symptoms. So infratentorial lesions, they can present with headache, nausea and vomiting, which can occur in both infra and supratentorial. Now specifically, this is going to be more associated with gait disturbance, ataxia and vertigo. So if your patient is coming with disequilibrium kind of things like gait disturbance, ataxia, vertigo and all, so think that it is infratentorial. The tumor might be infratentorial. Since we have the brainstem infratentorially located, this was because of the cerebellar involvement. Since the brainstem is located infratentorially, so your cranial nerve deficits in the brainstem lie your cranial nerve nuclei. So from the brainstem, your cranial nerves are going to arise. Therefore, cranial nerve deficits are going to be in infratentorial lesions. Now, what are the symptoms? According to that, the cranial nerve affection will be there. If the patient is having diplopia, so it is usually the sixth nerve that is affected, that is abducens nerve. If the patient is having facial numbness and pain, that is sensory sensation, sensory function from the face is affected, so it is the trigeminal nerve which is affected. If there is unilateral hearing deficit and tinnitus, then it is vestibulocochlear nerve. Unilateral. Over here, you get disturbance, ataxia, vertigo. It is kind of bilateral. It is total affection, while this is unilateral tinnitus. Okay. Then facial weakness will be because of this is motor. This was sensory. This is motor. Facial weakness will be due to affection of the seventh nerve. If the patient is complaining of dysphagia, it is mostly because of affection of the glossopharyngeal and the vagus nerve. Now, infratentorial lesions, they can even present with CSF obstruction, which can cause hydrocephalus and papilledema. Okay, now moving on to the supratentorial lesions, their manifestations. So the manifestations of supratentorial lesions, the symptoms depend on the location of the tumor. If it is a frontal lobe lesion, it will manifest as personality changes, dementia, hemiparesis, or dysphagia. Dysphasia, not dysphagia, dysphasia. Temporal lobe lesions, they present with memory changes, auditory or olfactory hallucinations, and contralateral quadrantonopia. That is, you can remember pie in the sky, because your optic radiations part passes through temporal lobe. If there is affection of the parietal lobe lesions, it can cause contralateral motor or sensory impairment. How motor? Why motor? Because I think 30% of your corticospinal tract origin is from the parietal lobe too. And it can also cause apraxia. Apraxia is basically you're not able to carry out learned motor movements. Like if I tell you how to light up a matchstick, that person, because he's having parietal lobe lesion, will not be able to light up a matchstick. Then comes the patient can present with homonymous hemianopia. Now moving on to occipital lobe lesion. If the tumor is in occipital lobe, the patient may show with contralateral visual field defects or deficits. And alexia. Alexia is like he will not be able to identify the written words. So he is able to see, but he is not able to identify what is written or what he is seeing. Like if I show him an apple, he can see an apple, but because it is in the occipital lobe, the lesion, he will not be able to identify in his brain that it is an apple. So that is it. Moving on to the imaging studies done for cerebral tumors. The initial workup generally involves a CT scan of the brain. The CT scan, it is the initial workup. This CT scan provides us a rapid means of evaluating changes in the brain density, such as if there is any calcification, if there is a hyperacute hemorrhage that is less than 24 hours old, or if there are skull lesions. So a CT scan can help us to detect it. Next is MRI. Now MRI of the brain is the gold standard modality for diagnosis, for pre-surgical planning and post-therapeutic monitoring of the brain tumors. So for everything, MRI is the gold standard. Now out of MRI, we can have different types of MRI. We use various techniques in MRI. So first technique is gadolinium. Now this is an enhanced MRI. This is not some technique. They're just putting a contrast and seeing. So gadolinium is the contrast that is used in MRIs. Gadolinium enhanced MRI. It is very sensitive for demonstrating defects in the blood-brain barrier and for small metastases, which are less than up to 5 mm. Also MRI can be used, the gadolinium enhanced MRI, it can be used in patients that are allergic to iodine. Iodine is the contrast used in CT scan, and also in those with renal failure. Now advances in the MRI techniques have evolved from strictly morphology based imaging to a modality that encompasses all these: your function, physiology and anatomy of the brain. So you can actually not just the morphology of the lesion helping us. Now MRI has evolved so much that you can see the function. You can actually assess the functionality of a particular area, like functional MRI, physiology, anatomy and all. Moving on to diffusion weighted imaging. So diffusion weighted imaging, it helps us to distinguish between gliomas versus abscess. So diffusion weighted imaging, they primarily help us in they use Brownian motion concept, and hence they can help us differentiate between glioma versus abscess. Continuing with the imaging studies in CNS tumors, you have perfusion weighted imaging. It helps us in predicting the response to radiotherapy in low-grade gliomas. Functional MRI. Now functional MRI is particularly you do an MRI in very thin sections and then you reconstruct it using computers, and then you can see the anatomy of the brain structure in the patient individually. So you can use the functional MRI for planning surgery for tumors in eloquent areas of the brain. Eloquent areas means the areas of the brain which have a particular specified function. For example, Broca's area in the dominant hemisphere. While if you go into the non-dominant hemisphere, the inferior temporal, inferior frontal gyrus, you will not find any particular function. So that would be your non-eloquent areas. So if you have to approach the brain or the tumor is in the eloquent areas, you can use functional MRI and you can plan surgery for tumors there. And this can help us to enable radical resection with less morbidity. So you can remove, because brain tumors, you are going to cause a lot of morbidity. Neurosurgery does not usually have a very good prognosis. The patient can go into paresis or some deficit. So functional MRI can help us into radical resection of the tumor with less morbidity.
It doesn't mean all neurosurgeries have bad prognosis. They do have variable prognosis depending on the lesion. Moving on to diffusion tensor imaging. It can help us to demonstrate the effect of tumor on the white matter tracts. Diffusion tensor imaging. MRA, that is MR angiography. Now angiography, so you have got, it is basically relating to your blood vessels. You're going to visualize the blood vessels. Since it is MRI, it is a non-invasive modality. And it is used to evaluate the vascularity of a tumor or anatomical relationship of a tumor to that of normal cerebral vasculature, so that when you're operating, you might not hit any of the major vessels or veins or arteries. Coming to the treatment of brain tumors, we'll look into the general aspects. So medical management that we use for CNS tumors prior to surgery are dexamethasone. Now dexamethasone is recommended for the management of brain tumors because of its propensity to reduce peritumoral edema by stabilizing the cell membrane. An antiepileptic drug is also recommended for tumors close to the sensory motor strip. Mannitol administration prior to dural opening and operative resection is often used as it will reduce your intracranial pressure. Now surgical management, general aspects. The intraoperative microscope, this technique provides superior illumination and magnification, thereby allowing resection of tumors from critical areas through small cranial openings. So you needn't dissect much areas of the brain using intraoperative microscope. So other techniques used for brain tumor surgeries are CUSA, that is cavitational ultrasonic surgical aspirator. So as you can see, it is an aspiration technique. So it is going to simultaneously break up and suck away the firm tumors while operating on vital structures, and it is going to protect the vital neural and vascular structures. So intraoperative USG, it provides real-time imaging of the tumor and the cyst in the subcortical and deep areas of the brain. Next technique that we use is intraoperative CT or MRI. So while you're operating, you get a CT or MRI. So this helps in on-table imaging of the extent of resection. So how much of the tumor have you removed right on the table. And the CT and MRI also allows real-time visualization of biopsy needle and extent of resection that you have done within a target. Next is image-guided CT or MRI, frameless surgical navigation. So you do not need a lot of, you take like 64 cuts and all. Here it allows instant and accurate localization of the tip or probe during a craniotomy. So you are doing it and you can put the tip of the probe and you can display the point on a pre-op CT or MRI. Okay, now the primary goal of carrying out a surgery in case of brain tumors is to get the histological diagnosis, and it is to reduce the mass effect caused by the brain tumor by removing as much tumor as safely as possible and also to preserve the neurological function. So the decision between a needle biopsy and the more radical surgical resection depends on the location of the tumor, the size of the tumor, its sensitivity to radiation or chemotherapy. Because if it is sensitive, you would not, if it is highly sensitive, you do not have to go for radical surgical resection. Rather, you can get a needle biopsy, you can see the histology, you can give radiation and chemotherapy instead of going for surgical resection. Then it also depends on the patient's pre-op Karnofsky performance score. And in case if it is metastatic brain lesions, then the systemic status of the primary cancer. So all this helps us decide whether we should conduct a biopsy on the patient or a surgical resection of the tumor. Okay, so with this we come to the end of CNS tumors part A, that is general aspects. In part B, I am going to cover individual intracranial tumors.